Most dental treatment rooms aren't that great for consultation. Have you ever been seated in a large empty restaurant with your back to the space and your face to the wall? It doesn't feel great. It's why most restaurants commonly have four-person tables set against the wall with patrons on either side, so that no one person is forced to have their back to the main body of the space. On the other hand, further into the center of the dining room, there are circular tables with patrons facing in every direction. It's not a problem. Clearly, placement in a room matters. The typical dental treatment room of 10 or 11 feet in length, when using typical dental patient chair, has the patient 3 or 4 feet from the outside wall when in the upright position. Quite frankly, that's a very odd place to be sitting in a room, and it's odd for other reasons as well. Greeting a new patient this deep into the room requires the doctor to shout an alert at entry, forcing the patient to try and turn around and greet the intruder. Alternatively, the doctor can sneak up on the patient, startling the heck out of him. Or worse, he or she can enter like Kramer in Seinfeld. None of these approaches is acceptable, which leads some doctors to have the new patient be met in consultation, thus unfortunately instituting a forever bottleneck to on-time performance. The patient waits for you there, which is weird. You get stuck chatting with the patient when you're in the room because you've got to coordinate getting back out of there. Little pre-prep work gets done unless you bring the patient to a treatment room first, then bring them back to consultation, and then you need to go ahead and do the rest of an exam, and so you've got to bring them back into a treatment room. That is a good flow. All of this just doesn't make a lot of sense. So let's go back to that treatment room geometry and discuss other challenges that it presents. And then we'll figure out how to solve these. Since the patient chair is centered in the room side to side, if the doctor hopes to converse with them in a seated and thus more reassuring and co-equal position, the conversation happens in a tiny corner of the room. As dentists, we get used to this, but think about it for a moment. You never have had this kind of meeting in a house or a normal office environment jammed into a tiny corner of a room, and so it just doesn't work well for healthy consultation. Quite frankly, it's weird, and dentists are just used to it. Patients aren't, which is exactly why doctors that are good at treatment planning tend to move patients out of the treatment room and into a consult room, which it turns out patients don't actually like. The good news is that there are a couple of design solutions to this problem that are good methods for remediation in the right circumstance. And later I'll get a chance to talk to you about a solution that will work in most treatment rooms that don't use over-the-patient handpieces. Remember, our goal here is to make treatment rooms comfortable to meet and greet patients. The first alternative is to change the orientation of the entry door in relation to how the patient chair is oriented. There are two different choices of this alternative. The first alternative is toe entry. Toe entry permits comfortable greeting between patient and staff, and when in the upright position, allows the patient to be closer to the entry door, but not feel so weird about it. It also allows a normal face-to-face greeting. We'll talk about some disadvantages to these layouts later. The second choice is to rotate the room 90 degrees so the room can be entered from the side, generally near the toe. This also allows a more natural greeting. While both of these solutions permit more comfortable interaction with the patient in the upright position, both do create other conflicts. The toe entry room places the patient in an awkward position when in the down state regarding privacy issues, and the rotated room consumes much more hallway length per room, often limiting the number of treatment rooms possible within a given space. There's another solution that is fairly simple and generally requires a minimal amount of reconstruction or change. This involves the use of a so-called traversing dental chair. In a survey of recent dental graduates, we were surprised to find that less than 1% of the students had any awareness of the existence of this chair variant. Thus, we assume that the majority of younger dentists may also be unaware of this capability. The traversing chair was actually pioneered over 40 years ago during the highly creative years of the Pelton & Crane Company. Examples of the Pelton & Crane chairman chair are still in use today, oftentimes having been rebuilt by their second or third generation owners because of the comfort and feature set. The chair was discontinued during the costly acquisition of Pelton by Siemens. It was a great failure for all involved, and it led to the eventual demise of Pelton & Crane. The expense of potentially building the chair in Europe and then selling it through the dealer network was considered too costly. What traversing chairs do is they slide front to back as the chair top reclines, thus minimizing the change in position front to back in the operatory of the patient's head. What this does is subtle but significant. It allows the patient in the upright position to be seated much closer to the center of the room, a position that feels much more natural to them. This placement also creates easier access to the patient by the staff members and to the doctor in greeting, and allows much more room at the toe of the chair for staff to have initial conversations face to face. When we're treating patients, we have to invade their personal space. It's an unavoidable function in our usual working distance. But if we can start and finish our interactions with a more comfortable conversational position, the patient will have a much better experience. And a comfortable patient is both easier to treat and more receptive to discussing care. As a result, offices that use one of these solutions in treatment room design and equipping find that they can much more successfully accommodate both in-room consultation and in-room checkout. If you have any questions about in-room checkout and case presentation, please reach out at any time to my team at Design Ergonomics. Thank you.